a very good afternoon to all of you. We are three judges here at the moment. Myself, Dr. Jignesh Taswala, Madam is Dr. Jeenu Priya, and Dr. Alka Gupta. Correct? So we start with the first session, that is dermoid excision with smile lenticule patch graft, and we have Navneet Sidhu to do the presentation. Over to you. You have 8 minutes, I suppose.
Thank you.
Yeah, you have 8 minutes. So 6 minutes and 2 minutes discussion.
So good afternoon, everyone. I'll be presenting the case of a 20 years old female who presented with a limbal dermoid. Can we start this video, please? So there are no financial conflicts of interest. So this limbal dermoid was present since childhood. So we started with a local peritomy around the limbal dermoid, and the conjunctiva around the dermoid was excised using corneoscleral scissors, and the sclera was also removed from around the dermoid. So this video is showing the scene, the local peritomy, followed by cauterization of the bleeding blood vessels, since limbal dermoids are known to have quite a rich blood supply and they bleed quite vigorously. And the dermoid was first dissected using a crescent blade in a lamellar fashion. So the crescent blade was used, all the bleeding vessels were cauterized side by side, and in a slow fashion, carefully the dermoid was dissected. All the remaining fibers from around the corneal stroma were also tried to be removed in the same manner. So after the thorough lamellar dissection of the dermoid was done, as I said, the dermoids are quite rich in blood supply, so this case needed quite multiple cauterizations in between. All the remaining deep fibers were also removed, since any remaining fibers of the dermoid, they are known to recur. So it's always tried that we shave off all the dermoid fibers, and the use of intraoperative IOCT was done to look for the thinning and for the residual bed. After the dermoid was excised, we did a corneal tattooing in the bed first using silver and gold dyes, gold chloride and hydrazine hydrate, and this produces a goldenish blackish color. Following which we applied glue to the bed, and smile lenticule grafts were stuck to the corneal side of the graft. Since there is thinning, so we don't want any future Delin formation or any future thinning in this area. And since the lenticules are of variable thickness, the thickness of the lenticule can vary from approximately 50 microns to 150 microns. So interoperatively, based on the thickness and the depth of the dermoid, we had to apply around 3 lenticules. Fibrin glue was used to stick the lenticules, and the peritomy was also closed using fibrin glue. So after the glue was applied and dried, we did a second round of corneal tattooing using gold chloride and hydrazine hydrate, and intraoperative IOCT was done to confirm, and as we can see that this was the lenticules were almost in level with the host cornea. So the main purpose of tattooing in the same sitting was to provide a good cosmetic outcome to the patient as well. A BCL was placed at the end of the surgery to prevent the lenticules from being rubbed away. This was the post-operative day 1 picture, and the patient was doing well even up to 3 months post-operatively. She had a good gain of vision. She had 6/9 vision post-operatively unaided, which improved to 6/6 with glasses.
Very good. Lots of questions. What is the anesthesia have you used in this?
So we used peribulbar anesthesia with lignocaine and bupivacaine.
Fine. Why 2 lenticles were used?
So we could not actually preoperatively decide the number of lenticules which would be needed. Intraoperatively, as per the depth of the dermoid, we had some 4-5 lenticules in backup. So
Okay.
according to the depth
How
of
do
the
you
dermoid.
size the lenticule?
So lenticule was of variable thickness. Size is standard only for all the lenticules. So our main motive was to cover the corneal part.
Okay.
So that is accordingly.
Fine.
Thank you.
Second one is Dr. Palani Muthu. Palani Muthu is here. Ravi Kumar. Yeah. इसमें वॉच नहीं चल रही है ना टाइम का अरे वो
भाई timer लगाओ. Timer. We don't see the timer.
Good afternoon, everyone. Good afternoon, judges. So my presentation is about minimum steps on maximum outcomes. The challenges in doing effective volume cataract surgeries in the free eye camp are cost, time, and delivery. Cost, reduce the usable consumables, reduce the usage of consumables. Time, more number of surgeries in the OT, and deliver, you have to give the best results because the follow-up is very less. So this is the video how we perform surgeries in the camp. You will do always a temporal incision. Conjunctival flap is created. The external incision is about 6.5 mm length, 1.5 mm away from the limbus. Two side packets were made, the both ends of the incision. And then the same plane, the incision is completed. The inner lip is about 1.5 mm, is very important. That is the wound integrity will be good. Side port is created. Visco is used to fill up the antechamber. Here, using cystitome, the CC is done with the cystitome using tearing and shearing force in one step. Fairly large rexis always will aim. Antechambers entered using Keratome. Most of the camp cases are hard cataracts, so we use cystitome. The nucleus is hooked and lifted using cystitome at one pole with side-wise movements to separate from the capsular bag. Then we'll put viscoelastic filled under and over the nucleus. Using sandwich technique, we deliver the nucleus. Cortex was done with simple cannula. Holding the anterior fibers of the sticky cortex with the sweeping motion, it all cortex are stripped out. The anterior chamber is filled with air bubble. This is our key step. Here, rigid IOL is implanted. You can see the leading optics sliding under the capsule margin as goes and settle in the capsular bag. Then the trailing optics is dialed using Simcoe cannula with the irrigation on. So that's the end of the surgery. So no need to wash the viscoelastic, and the time won't be wasted here. That's a stromal hydration, and we won't do cautery, and the control flap is reposted. So all surgeries goes in within 3 minutes. This is a few videos how we implant under air bubble. You can see the leading aptix goes under the margin, and then with the irrigation on, the IOL is dialed into the bag. This is second case. Again, the IOL is implanted, and with the irrigation on, dialed into the bag. The third case, the similar steps is used here. See, the cornea is very clear. The post-op results are very good. So these series of cases will showing that even a foldable IOL also we will implant in few cases.
Hi everyone.
Sorry.
Can you show the last slide again? Yeah.
1 second. Sir. It's not going.
It's not
You
steady.
play this video.
Leave it, leave it. You can just tell us what are the advantages of
this
pneumo
video?
implantation. The last slide is not
It is
steady.
there. Sorry, okay. So what are the advantages of air bubble? What we are using is prevents wound leakage and inflow of surface fluid, endothelial cell loss during vigorous washing of viscoelastic that is used for IOL implantation, seals DM detachment that occurs during various manipulation at the wound site. Air bubble is safer to the endothelium with added anti-inflammatory property also. Studies are there. Avoids stars that may occur when left out viscoelastics. So successive volume surgeries, as you all know, improving surgical outcomes, reducing the cost, committed teamwork and efficient surgery, but reducing and changing few steps to give best result to the patients. So because the patients don't have followability. Thank you, sir.
Fantastic. Here also, if you start doing under topical, you will save further time. That is what I would suggest.
Yes.
Second part is even the CCC. If you do it under this thing, you don't use visco at all during this. So that is a good point. Third is pneumo implantation, all that you are doing definitely saves time, because putting in and out all the viscous and washing out itself consumes a lot of time, and of course the subsequent complications that you have. So nice that you have. Ma'am, any questions?
Have you tried any hydro insertion of lens?
Yes, madam. That is also.
Which one is better, hydro or?
In my hands, if you do bimanual, if you do bimanual, definitely hydro implantation is one of a choice. But we are reducing the steps. We don't use the side port because it's a volume surgeries. Side port, one side port only. The second side port only for to use the dialer to hold. That's all. We need not do the extend for the hydration for the bimanual actually.
But you can also use this hydro insertion to save the cost of cataract surgery.
Yes, madam.
You
Yes,
can
madam.
use it.
Yes, madam.
Okay.
Thank you so much.
Sir, any junior is doing these surgeries or only senior consultants? are doing?
surgeons only.
So,
Fantastic. Thank you very much.
Thank you.
Sir, you would like to ask anything? Sir? Nothing. Thanks. Thanks a lot. Wonderful presentation. Take your seat. The next, I think, ma'am will announce.
sir, I would like to call Dr. Arnab Mandal for the next video.
Good afternoon, everyone. My topic is botulinum toxin injection in hemifacial spasm. Botulinum toxin injection in hemifacial spasm.
What has happened? Why are you coming further?
Sound is not sound, there is sound. Hemifacial spasm is characterized by unilateral involuntary tonic-clonic contractions of the muscles innervated by the facial nerve. It is commonly seen in women 5th to 6th decade of life. The condition is commonly idiopathic but may stem from irritation of the 7th cranial nerve at any point in its course. It is disabling due to social embarrassment and in extreme cases can interfere with vision. The disorder is characterized initially by brief spasm of the orbicularis oculi which later spreads along the distribution of the facial nerve involving corrugator superciliaris, procerus, zygomaticus major and minor, mentalis and sometimes platysma. Botulinum toxin type A acts by blocking presynaptic release of the neurotransmitter acetylcholine at the neuromuscular junction with reversible chemical denervation of the muscle fiber, thereby inducing partial paralysis. Botulinum toxin is available in dry form. 50 units of botulinum toxin A is reconstituted with 2 ml normal saline 0.9%. Thus, the reconstituted concentration is 2.5 units per 0.1 ml. In sitting position, all the involved muscle are clinically examined and dosage are determined. Injection sites are cleaned with betadine solution and spirit and marked with skin marker. Using 30 gauge needle, 2.5 unit is injected into procerus and corrugator superciliaris. 2.5 unit above the eyebrow into orbital part of the orbicularis. Each 2.5 unit into orbicularis oculi of the upper eyelid, lateral and medial part. Each 2.5 unit into orbicularis oculi of the lower eyelid, lateral and central part. Then patient is asked to smile and zygomaticus major and minor is palpated and 2.5 unit is injected into it. And then 2.5 unit into depressor angulioris, then 2.5 unit into mentalis muscle. And then 2.5 unit into the lateral canthus. Injection into the preseptal part is avoided to prevent levator muscle paralysis and subsequent development of ptosis. The inferior part of the lower eyelid is avoided to prevent lacrimal pump failure. Injection into the nasalis muscle can obstruct breathing and injection into the orbicularis oculi can result paralysis of the mouth and drooling of the saliva. Post-injection side effects may be seen like ptosis, lag of thalamus, epiphora, diplopia, facial asymmetry and facial weakness. All these unwanted effects are transitory and resolved over a period of time. Spasm of all the involved facial muscles had gone on 3rd week follow-up and patient was also doing well on 1st and 3rd month follow-up. Here is showing pre and post injection facial appearance of the patient. Reappearance of the spasm may be seen, hence repeat injection may be needed. So, hemifacial spasm may be safe and effectively treated by targeted denervation with botulinum toxin injection.
Nice. How many units do you utilize for this? That now that you have reconstituted it, how many units have you utilized in this?
Total 25 to 30 units.
What about the rest of the units? How do you preserve it, and how long does it remain viable?
Actually, according to the actually in vial it is written it should be used within 48 hours, but we kept it for 1 month. But the result.
How do you preserve it? Let the students know. That's why we are asking you now that you have done it.
Actually, it should be preserved in 4 to 8 degrees centigrade temperature.
Very good.
We kept in fridge in that. For that normal fridge, it should be kept in ILR. Ideally, should be kept in ILR, but we kept in fridge, normal fridge.
It should not be kept in the deep freezer. Remember this. Otherwise, it loses its viability.
Yes.
It has to be kept at 4 to 8 degrees in the door compartment of the freezer. So that is one. Second, sir, any question?
You want to ask?
Sir, what was your angle of injection?
Sorry?
Do you think it should be injected slightly more vertically or?
It depends on the muscle original insertion. In case of Procerus, we have to inject vertically.
Yeah.
But in corrugator superciliaris, it is to superficial part, deep part. For the oblique superficial part, we put it in superficially. It is the injection is given into the muscle, deep in the muscle. So according to the muscle original insertion, we have to put in that area. Like for orbicularis oculi, we put superficially because orbicularis is a superficial muscle. It has also deep part, but
How long is the effect of this?
usually
And,
in my
yeah.
practice I have seen in persist almost 3 to 6 months. After 6 months, repeat injection is really needed.
Actually, one small tip I would like to share is while you're injecting, always aspirate. So you're not in the blood vessel.
Yes, sir.
Remember this. You haven't mentioned. You just said, I injected.
Yes.
So always aspirate that you are not in a blood vessel before you do it. So,
Have you done your own modification in this standard procedure? Or you have followed the standard procedure? I mean, what others are following it?
Actually, should be follow the standard procedure, but I have done some modification.
What modification?
Actually, the orbital part of the orbicularis I give at that position, that part 2.5 minutes, and also I give some lateral canthal area of the orbicularis. The platysma is not too much involved in these cases, so I avoided. Thank you.
thanks a lot. Wonderful presentation and good question and answer session. Let's restrict 2 minutes for the question and answers and 6 minutes for this. The next sir is going to announce. Sir, fourth one. Sonam. You have to announce.
All right.
IOCT wala, sir. Fourth one.
Well, the speaker is Dr. Sonam Yangzis.
Thank you, sir. Could you please check the volume? It's a pre-recorded video. Good afternoon, everyone.
Large iris cyst in an infant. There are no financial disclosures.
Timer please. Timer please.
A 6-month-old infant was brought by her parents with complaints of inability to open the right eye since birth. Her antenatal history was unremarkable. On examination, her intraocular pressure was 10 mm mercury with presence of a large iris cyst obscuring the visual axis. Her left eye was within normal limits. Asocio to the right eye shows a large iris cyst filling the anterior chamber, measuring up to 2.8 into 6.7 mm. UBIM also shows similar findings. Management options in primary iris cysts include cyst aspiration alone, but this is not routinely practiced as this is associated with higher risk of recurrences. Other options include injection of sclerosing agent, which has lesser risk of recurrence. But sclerosing agents are quite toxic and caution has to be practiced as it can lead to local toxicity. Other methods like en-bloc excision is associated with greater risk of collateral damage to the surrounding tissues along with intraocular pressure elevation, inflammation and corneal decompensation. We did a literature search to look for a non-toxic alternative. We came across this paper which shows use of fibrin glue for a large iris cyst with good results. We wanted to go ahead with this technique because fibrin glue is biocompatible and its efficacy has been proven for intraocular use as well. In our case, we believe the fibrin glue would facilitate adhesions between the cyst wall, thereby enabling complete resection without any collateral damage. We went ahead with a stepwise approach, first step being aspiration of the cyst contents, followed by injection of the biologic fibrin glue inside the cyst cavity, then resection of the walls at the later setting. IOCT guided iris cyst aspiration with fibrin glue. Use of IOCT helped us in visualizing the cyst in real time. We could localize the position of the needle inside the cyst cavity that helped us in preventing any collateral damage. First step was aspiration of the cyst contents. We can see the cyst wall collapsing. This was followed by injection of the first component fibrinogen inside the cyst cavity, followed by second component. The case was then closed. Cytology revealed absence of malignancy. At 6 weeks follow-up, her intraocular pressure was 10 mm mercury with collapsed cyst walls. We followed this case with third step, that is cyst wall excision. After injecting viscoelastic under the endothelium, iris spatula was used to separate the cyst wall from the endothelium and the angle. This was followed by excision of the cyst, which was sent for histopathological examination. Remnant of the cyst was then removed with the help of cutter. Peripheral iridectomy was performed and the ports were sutured. Histopathology showed benign pigment epithelial cells lined by non-keratinized stratovascular epithelium. At 4 weeks, we can see there's absence of any recurrence. At 1 year follow-up, the cornea has cleared out with absence of any recurrence. The visual axis was parallel. Patching therapy was continued. So to conclude, biologic fibrin glue can be considered as an alternative to toxic sclerosing agents. Stepwise approach ensures minimal damage to the surrounding structures. More studies are needed to prove the efficacy and safety of fibrin glue in large iris cysts. Thank you.
Very nice. This is one-off case that you have done, or this is subsequent you have done in only in the infants or
Yes, sir.
even adults?
So only in infants, especially for a large iris cyst. If it's a smaller cyst, just observation. If it's a very small cyst not involving the visual axis, then one can observe also, and one can only aspirate or maybe cut also. But this being a very large cyst involving the visual axis, there was a risk of recurrence also, sir. Also risk of formation of cataract and endothelial damage. So we looked for this particular thing, sir. And the second infant, sir, recently operated just a week ago, sir.
Okay.
So we are following that patient. also.
While you aspirated, the IOP goes down and the
Yes, sir.
wall abut each other.
Yes,
How
sir.
do you inject the fibrin glue? How do you find the space that you are again into the same space?
Yes, sir. So when it comes to injecting any other component inside the wall cavity, we can use air bubble to inflate the cyst again, so that it's easier. Here in our case, we use the IOCT, so it helped us in guiding. If
What
it
did
was,
you use?
The
Yes,
microscope
yes.
integrated
Okay.
OCT, sir. Otherwise, one can use BSS or air bubble inside the wall, inside the cyst cavity, just to inflate it so that it's easier to inject.
Another idea is need not empty out the whole thing. Keep a little.
Yes.
You have an idea that there is space in between. Inject it, automatically the rest of the things flow out.
Definitely.
Because fibrin glue is quite heavy and consistent.
Yes, sir.
Any questions? Sure. Nothing? Thanks a lot.
Just a minute, just a minute. I have a question. Did you notice some complications so far as lens of the patient was concerned?
So there was just this localized synechiae that we saw, localized synechiae, sir. Otherwise, lens was clear, sir. That synechiae was due to that the cyst sitting on it for a long time.
During this 1 year follow-up period, patient didn't develop any cataract.
No, sir. No, sir.
Lens remained clear.
Lens remained clear, sir.
Okay.
Yes, sir.
Very
And
good.
photophobia also resolved completely. Otherwise, she couldn't open from birth only. They could not open the eye. Yes, sir.
Very good presentation. Thanks a lot. The next presenter now we have got is the fifth presentation, dancing worm in the anterior chamber, and the presenter is Ranjita Amanatya. Is she there? Yeah, please. Please reset the timer. Done.
Okay. Hello everyone. My name is Ranjita Amanatya and I am a second year PG resident from Odisha. Today I would like to present a case of a dancing worm in the anterior chamber. A 12 years old male child presented at the eye OPD with the chief complaint of the sudden redness, pain, photophobia and lacrimation in the left eye for 5 days. General physical examination revealed a healthy looking patient without subcutaneous nodules or swelling on any part of the body, suggesting no lymphadenopathy. There was no history of fever, itching, or swelling in any part of the body, but history of pond bath was present. Chest and CVS examination was essentially normal, and there was no hepatosplenomegaly. No abnormality was found in the surrounding ocular adnexa. Moving on to ocular examination, his best corrected visual acuity was 6/6 partial in the affected eye and 6/6 in the right eye. Intraocular pressure was taken by the non-contact tonometer, which was 16 mm mercury in the normal eye and 18 mm mercury in the affected eye. The slit lamp examination of the left eye revealed conjunctival hyperemia, clear cornea, a moving white object in the anterior chamber. The iris was normal and the lens was clear. The right eye was within normal limit. So a diagnosis of a live anterior chamber worm was considered. Coming to blood reports, full blood count revealed 52% eosinophilia, but midday samples of the peripheral blood were negative for microphilia. Then, stool microscopy didn't show any ova or parasites. Moving on to the treatment plan, the patient was admitted for the surgical removal of the worm. While the patient was under general anesthesia, the eye was first stabilized. An operating microscope was used and a limbal stab incision of size 2.8 mm was given. Then a tunnel was created using a crescent knife. Xylocaine restricted the movement of the dancing worm, and then fully intact immobile live adult worm was removed from the anterior chamber. The procedure ended with an anterior chamber washout followed by a subconjunctival injection of a combination of steroids and antibiotics. The worm was then sent to microbiology department for its identification. Post-operative treatment included dexamethasone eye drop 6 times per day, atropine eye drop twice daily, and a combination of steroid and antibiotic ointment for evening. The doses of the topical steroid were tapered down over 2 months. Microscopic examination revealed that the worm was white, cylindrical, curved, about 0.8 to 0.9 cm in length and around 0.4 mm in breadth. The worm had blunt anterior and the posterior end of the body. There was a vulval opening near the mouth and the uterine structures couldn't be seen. The worm was then identified to be adult female Loa. So that brings me to the end of my presentation. Loa is also known as African eye worm. It is a nematode which causes loesis through bite of the Chrysops flies. The infective microfilaria of the Loa burrows into the human skin when the Chrysops vector takes blood meal. Children usually do not complain, and this is the cause for the gap between the onset and the diagnosis. The patient, in our case, belonged to a rural region in Odisha Our patient presented with a painful red eye with a decreased visual acuity. These signs could mimic other eye pathologies. A careful slit lamp examination was the key to the diagnosis. Slit lamp examination should be done under low illumination to avoid missing the parasite in the anterior chamber. A decrease in the visual acuity observed in this case was more linked to the central position of the worm at the presentation, that is in the visual axis. Surgical removal of the worm was curative and relatively simple and should be done as soon as possible to prevent structural damages in the anterior chamber. Our patient didn't develop complications owing to the early presentation and adequate management. To conclude, I would like to say that ophthalmologists from the endemic areas need to be aware of this diagnosis that can mimic other eye pathologies like the uveitis or idiopathic intraocular inflammations. Careful examination, prompt diagnosis, and early surgical removal of the worm from the anterior chamber can reduce the ocular morbidity. Systemic therapy may be required to cure the infection. The examination of the worm is better to be made by an experienced parasitologist, and treatment is better to be made by an experienced ophthalmologist in conjunction with an infectiologist. Personal protection should be done by using the skin repellents and wearing the long sleeves and covered clothing to minimize the chance of a bite from Chrysops fly. Thank you very much for
Nice
your attention.
presentation. 2-3 questions is, one is what anesthesia 12-year-old have you used in this under GA?
Yes, sir.
But
We did.
then why have you applied the superior rectus?
Sir,
Why is the superior rectus required once you are under the GA? You are just going to aspirate it.
yes,
Why is
sir.
superior rectus used?
If any further movement might.
Under GA कहाँ movement होता है madam? Anyway, so that is one point I just noticed. The second is how big is the incision? You had used an aspiration cannula to aspirate the worm.
Sir, 2.2.
Not physically removed because it was a dancing worm.
Yes.
So how do you?
Sir, we gave xylocaine, which restricted the movement of the worm. Then we took the worm through the keratome.
The best way would have been you use what we say oculon to anesthetize it, and with a forceps you can pull it out fully. Once it is anesthetized, it stops moving. Why do you require a keratome? While keratome you can cut through the worm. I mean, just the suggestion. Any opinion of the judges, sir? So overall, it's a good this thing. Just remember, superior rectus was not required. I was just feeling under GA hai.
Yes.
So why do you require an additional step? You're doing in a child. You are, I mean, it's if you damage the superior rectus while taking, it's a young child. So small little steps. I think we should be, as a surgeon, we should keep it in mind. Thank you, sir. Madam, next.
Next is Dr. Afreen Bari.
Good afternoon, everyone. I am Dr. Afreen Bari. And I'll be presenting on a series of cases of abandoned cataract surgery from your table to mine. So we'll be discussing first case of Descemet's membrane detachment, a case with stromal edema and epitheliopathy presented to us on IOCT. We could observe that there was a Descemet membrane detachment involving the center. So this case was taken and using intracameral isoexpansile gas, it was injected such that it is below the Descemet's membrane, and we can see in the real time view that the Descemet's membrane has attached back. At 3 days follow-up, we could see that the stromal edema resolved and there was a decrease in the stromal edema with no Descemet's membrane detachment. Patient's vision also improved to 6/6. This is the second case which was referred to us. We can appreciate that patient's vision improved from hand movements to 6/6. The third was the most challenging case. It was a case of brittle cornea syndrome, which was referred following abandoned cataract surgery. The surgeon had just made the incision and the incision had expanded. The AC was flat with the intumescent lens touching the endothelium. As we can see in this photograph, there was an intumescent lens touching the endothelium with flat AC. So this case, firstly, lens removal was planned. First figure emulsification was done, AC was formed. Then after doing the lens aspiration, all the cortical matter were removed and intraocular lens was implanted. However, since the cornea was very weak, a simultaneous lamellar keratoplasty was planned so that the wound does not gape back again. Using crescentic knife, the whole of the donor cornea was used for support. So we can see that on post-operative day 1 the AC was formed. Although there was some reaction, but the AC was formed and gradually on follow-up it settled down. So what we learn from all these cases is that from your table to mine, at a tertiary eye center we can see that there might be referral. The primary surgeon, it is important that a timely diagnose if there are any preoperative risk factors and or if there are any intraoperative problems, they should immediately refer the cases. And it is the duty of the second surgeon to prompt intervention and save these eyes. Because we know that in our country, in cases more than 50 years of age, cataract surgery complications are the third most common cause of blindness. So from your table to my table, let's save eyes.
Very nice.
So you didn't use air? Ma'am, in these cases, isoexpansile gas was used because a large DMD was there and we wanted tamponade for a longer time. That is why intracameral air is also equally effective.
Yeah, because we use air for DMEC also.
Yes, ma'am.
So-
It is equally effective. But in
So what
this
was the
particular
reason for using gas instead of air?
Ma'am, just for a longer tamponade we used. However, intracameral air is as effective as isoexpansile gas. However, if there is superior part of the Descemet's is involved, in those cases, just a longer tamponade.
I think air is as effective as gas.
Yeah, air is as effective, but of course, what you said is also there. When a longer period is required, we use SF6 or any of the gases. My question was, what about the third case? Why it was abandoned? Did you find out the reason? No surgeon is going to leave cataract this way.
Sir, actually the patient, the surgeon had just made the incision, and as he was maneuvering, the incision just expanded. From a 2-point incision, it expanded to 4.5, and the lens had come anteriorly. So he was unable to, he couldn't understand that what
So it
had
was in
went
your
wrong.
OT itself and madam handled it, or
No, it was a referred
earlier
case
done?
from another
What was the
hospital.
gap period in between?
Within 6 hours he came to us.
Okay, fine. Thank you.
Thank you, sir.
Any question? Sir? Thanks. Third one about last. Mystical vanish.
So I would like to call Dr. Ashwita,
No, Ruju.
Dr. Ruju Unadkat,
Yeah, mystical vanish.
mystical vanish.
The mystical vanish. Kissing nevus managed by a radiofrequency derma abrasion. Nevus, a Latin word for maternal impression or birthmark, indicates a circumscribed, non-neoplastic skin or mucosal lesion usually present at or soon after birth. Melanocytic nevus is a benign proliferation of melanocytic cells which are arranged in nests in epidermis, dermis, or other tissues. Congenital divided nevus of the eyelids, first described in 1919 by Fuchs, is a rare form of the eyelid nevus, usually involving contiguous, equal portions of the unilateral upper and lower eyelid margins. Owing to its extension to the lid margins, the edges of the tumor touch or kiss during the closure of the lids, rendering the name kissing nevus. It is also known as split ocular nevus or panda nevus. Normally during intrauterine 6th week, the lids appear as ectodermal protrusions and grow toward each other and fuse at 24th week, after which they gradually separate. Melanoblasts originate from the neural crest and migrate during 12 to 14 weeks of gestation to colonize the epidermis. During nevus formation, the defect in melanocyte migration produces a split nevus. A similar interesting process of congenital divided nevus has also been described elsewhere in the body, including the penis and between fingers. However, this is much less common than the eyelid. Based on the size, these can be divided into small, less than 1.5 centimeters, medium, 1.5 to 19.9 centimeters, and large, more than 20 centimeters. Based on histology, these are organized into three main categories: junctional, intradermal, and compound type. In course of time, there is a risk of malignant change ranging from 2 to 30% in the nevus, giving rise to melanoma. High index of clinical suspicion is required in pigmented lesions with a history of growth, alteration in pigment pattern, vascularity, and associated inflammation. The surgical management options vary from full thickness excision biopsy followed by lid reconstruction for lesions invading the deeper dermis layer to radiofrequency dermabrasion for lesions limited to the superficial dermis. In this case, after proper aseptic precautions and infiltration of local anesthetic agent, we used monopolar radiofrequency probe parallel to the lesion to gently abrade the superficial dermis layer till the appearance of pinpoint bleeding. Care was taken to avoid lash follicles and the deeper dermis layer. Successive sessions were planned at an interval of 6 to 8 weeks for complete excision. To conclude, radiofrequency dermabrasion gives excellent cosmetic outcomes with minimum morbidity in cases of congenital divided nevus of the eyelid.
Very nice. Fantastic. It's a procedure which has to be done for cosmetic purposes also. But what is the follow-up for these cases? How long it has been? And have you seen any recurrence? Such cases at least?
No, sir. No recurrence was seen,
How
and
long was the follow-up?
mean follow-up was 3 years.
3 years.
Yes, minimal scarring was noticed, but it is always better than a lid sparing cutler beard or any full thickness procedure.
To be on safer side, do you feel that use of some corneal sheet will be better?
Sir, actually, it was done on lid margins only, and care was taken at all point of time to not to touch cornea.
But you will not touch the cornea, but patient was moving the eye. That is why.
And the anesthesia in this that you have used?
Sir, it was frontal nerve block along with infraorbital nerve block, as we were dealing with upper lid and lower lid.
And what was the constitution? Only lignocaine 2% or with sensocaine?
Lignocaine.
Plain.
Plain
with
lignocaine.
adrenaline.
Yeah.
So, very nice. Thank you very much. Everybody has presented. Any questions, sir? For anybody? The person who just presented regarding the dancing worm, where is she? Has she left? One who presented the dancing worm, is she there? Or? Oh, she has left. Yeah, all the presenters should be there till the end. Anyway, Thanks a lot. Excellent presentation. We have actually finished right before time, so we'll have a small photograph with all of them. Thank you very much, sir. Any comments from each of one of you, all the judges, ma'am? Anything? The level of presentations was excellent. I really liked it. There are new cases and some unique presentations were there, especially regarding the nevus. Even I have seen it first time, how the junctional nevus has been taken care of. And the dancing worm, of course, we had seen plenty. And otherwise also good presentations. Thank you. Thank you for being with us. Thank you very much. We have ended the session. Let's have a group photograph. Thank you, AIOC, for making us the judge. Dr. Namrata Sharma, the Chairman Scientific Committee, and also the AIOS Chairman Scientific Committee. On behalf of all the judges, a big thank you.